Hello and welcome to this video lecture that will discuss section 40.4 on blood flow and blood pressure regulation. Our learning objectives are to describe the system of blood flow through the body and describe how blood pressure is regulated. So first of all, what is blood pressure? It's going to be the pressure that we are exerting on a blood vessel wall. It could be an artery, it could be a vein, it could be capillaries. But we do find that it is highest in the aorta that leaves the heart. And as it flows through the vessels of the body, we're going to start to see that the pressure decreases until we get back to the veins and it gets pumped through the heart again. Now, the fact that we have pressure in these vessels helps us get a pulse. We have these different pulse points throughout the body that you see listed here. We usually use the common carotid artery or the brachial artery, which should be a little bit higher as far as where we can palpate it, and radial artery that's closer to the thumb here. And so when that artery is going to have that blood surge through it, we are going to stretch those walls out, and then because we have elastic fibers within the artery, it will recoil back to its original size. And we could use this pulse to measure our heart rate, and that should be an average between 60 and 80 beats per minute. So as that blood pressure moves through, and we're going to discuss this a little bit more later on, but we have two different types of pressures. We have systolic pressure, which is going to be the highest type of pressure. Essentially, when our heart muscle contracts, especially the ventricles here, we're pushing that blood out of the artery and to the rest of the vessels within our body. And so our blood that is ejected out of the heart will have that highest pressure, like we said. Whereas diastolic pressure is going to be when the heart or the ventricles are relaxed. And so we will have a low amount of pressure because we're just allowing that blood to move through from the atria into the ventricles. And if we're looking at the blood in these other vessels, they are just flowing through as well. There's nothing really forcing and pushing them, pushing that blood into the vessel. And so this helps give our blood pressure number, which is a systolic pressure of 120 millimeters mercury over a diastolic pressure of 80 millimeters per mercury. And so many of you already know how blood pressure is taken, where we are going to put a blood pressure cuff, we put a stethoscope underneath on that brachial artery, and then we have something called a sphygmomanometer that is going to allow us to read the dial, essentially to measure the blood pressure. So when we inflate this cuff, we are going to pinch down on that brachial artery so there's no sounds that could be heard. As we twist the dial and allow some of the air pressure within the cuff to decrease, we are going to start to open up this artery and we will hear like a heartbeat. So that first sound that we hear is going to be the systolic pressure, and then you'll listen to it be, it goes do-do, 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 do-do. And then at the diastolic pressure is when we no longer hear any sounds because the artery will be completely open. So that will give us our diastolic pressure number, 80. Now, sometimes our blood pressure is higher than those numbers, and that is hypertension. And if they are lower, then we have hypotension. So here's a table that summarizes hypotension and then our varying stages of hypertension. You do want to have a good idea of what the ranges of these numbers are. You could see that this would be our systolic pressure, this would be our diastolic pressure. And if we have a blood pressure that is higher than 180 over a number that's higher than 110, we are in a hypertensive crisis and emergency care needs to be given. So you may be wondering, how does blood pressure fluctuate? How does it change? And the answer is that there's a lot of different factors. It could be due to our hormones, stress, maybe we're exercising, eating, sitting, standing. And so this blood pressure can change a little bit, but our goal is to always come back to homeostasis. So if we, though, are going to have chronic stress, of course, that is going to change your blood pressure to a hyper state. Now let's talk about how blood flows through the body. So we know that we have a couple factors that will help to regulate it. The size of our blood vessels, we've talked about vasoconstriction and vasodilation, and that is going to be changed using our smooth muscle within our vessels. We also have one-way valves, namely within our veins, to make sure that our blood flows in one direction. We can also find this in our lymphatic vessels. And then we have the fluid pressure of the blood itself. And so we can change some of these factors based on the body's needs and directions through our nervous system and our endocrine system in releasing hormones. So if we were to, let's say, sit down to have our lunch, we start eating, our body is going to vasodilate and allow blood to move over to our digestive organs to help with absorption and getting the nutrients that we need. Whereas if we are doing something such as exercising, we don't really care about that blood flow going to our digestive organs. Instead, we're going to vasoconstrict to those digestive organs and instead vasodilate to our skeletal muscles, because we're going to want to bring in that oxygenated blood for our muscles to be able to have great aerobic capacity. And we already discussed in the previous slides how contraction of the ventricles will create blood pressure, which propels the blood through our arteries. Now, once we leave the aorta, we are going to have that highest blood pressure, as we said. And as we flow through the body, we are going to start losing some of that pressure as we move away from the heart until we get back to the vena cava that takes that blood back to the heart. And then we're going to cycle it through and start back up here. Now, as that blood flows through, you're going to see the speed of the blood through here is going to change. We have a moderate amount of speed, and then as we move into the area of the capillaries, we are going to significantly slow that blood down. The reason for this is we want to slow the blood down to exchange with the tissues. So we're going to give off our nutrients and our oxygen to the tissues and pick up waste products like carbon dioxide. And then we can pick up speed a little bit more as we move in through the venules and then into larger veins to make our way back to the heart itself. Another way we can adjust this flow is through precapillary sphincters, and we're going to talk more about this in just a few slides. But before we get into that, let's talk about how we are going to get our blood back to the heart. So our blood flows to areas of our body from the arteries, because we want to go away from the heart with our arteries. And then once we utilize the oxygen from that blood, we put that blood into our veins. Now, our veins are not going to have as much pressure as we saw in this figure over here, right? Lower pressure here. And so we're going to rely on a couple mechanisms to be able to bring that blood back to the heart. First, we have our valves within our veins that is going to allow the blood to move through. And then if the blood tries to get pulled back through gravity, let's say down to our feet, these valves are going to catch the blood, and as we move the skeletal muscles around the vein, it will pump and push that blood back to the heart. So that's what we call our skeletal muscle pump. Another pump we have is our respiratory pump that will utilize our breathing in order to push against the veins and get that blood to move back to the heart. And so if we think about these mechanisms, it's going to be very important that we get up and move frequently after long periods of sitting so that our blood isn't going to pool in our extremities, we're able to use the skeletal muscles to push that blood through the veins back to the heart. All right, now let's talk about the capillaries and those precapillary sphincters. Now, when we have a true capillary, we are going to allow that blood to move through the artery into the arteriole and reach the full scale of our capillary. We move through areas known as the meta-arterial and along through our thoroughfare channel that you see in the middle here with the arrows. Now notice how we are going to also be able to move blood over into this network. At this point, these precapillary sphincters are relaxed, and it's allowing the blood to move through the entire capillary and exchange with the tissues. Now sometimes we have what we can call a false capillary, and that is going to be when we contract the precapillary sphincters here, which closes off the rest of this capillary bed here. So the blood is only going to be able to flow through the thoroughfare channel and make its way over to what we call the postcapillary venule. And in this way, at any time, only 1/4 of the body's capillary beds are open. This is going to affect the amount of perfusion we have within the tissues. When I use that word perfusion, I'm referring to the amount of blood that is entering the capillaries per unit time per gram of tissue, and the exchange that we have here within our tissues. Now, as we have our true blood capillaries, we are going to have fluid exiting the capillaries and into the tissues. Now, the way we're going to get that fluid back is that about 85% of that fluid will move back into the blood capillaries and eventually enter that venule. The other 15% is going to be drained from the interstitial fluid into these green structures here known as our lymphatic capillaries. And our lymphatic capillaries are small closed-end vessels that absorb this fluid, and we're now going to call that fluid lymph. Notice how the lymphatic capillaries are interspersed around most of our blood capillaries. And so we'll have a hydrostatic pressure within this interstitial fluid that will help push that fluid into our lymphatic capillaries. Once our lymph moves in here, we are going to move through a system of lymphatic structures to eventually make it back to our blood circulation. These lymphatic capillaries are going to be absent in our avascular tissues, which would include our red bone marrow, our spleen, and our central nervous system. So here is our system of lymphatic structures I was talking about. Let's review really quick. Our fluid is going to leave the blood capillaries and moves into the interstitial fluid, which is also found in our interstitial tissue out here. And then from that fluid, 85% of it is going to move back into the blood capillary and move into our venous system, whereas the 15% will be picked up by our lymphatic capillaries. It'll move through a structure which we call an afferent lymphatic vessel into our lymph node. We'll talk more about this in the next slide. And then it exits the lymph node through an efferent lymphatic vessel and then into lymphatic trunks, which then takes it to a lymphatic duct, and that will drain into our veins. Now, the lymph nodes that we saw in this picture here can be found all throughout the body, but the most common areas are going to be our cervical lymph nodes, axillary lymph nodes, and inguinal lymph nodes. And what they're important for is filtering that lymph to remove unwanted substances, especially our pathogens. So they're pretty small and oval shaped, and they are encapsulated. We'll find them in deep and superficial pathways of our lymph vessels kind of sitting near our arteries. And within our lymph node, we are going to have some connective tissue fibers that are going to support our white blood cells, namely the B lymphocytes, T lymphocytes, and macrophages. Now let's come back to our blood pressure. We kind of talked about how blood flows and other fluids flow through our lymphatic system. But when we think about blood pressure, we have to know that this pressure is produced by hydrostatic pressure of the blood itself against the arterial walls. Our hydrostatic pressure in our arteries closer to the heart is going to be at a very high level, just kind of how we referenced, where was it? This chart over here. So this is just a different figure in kind of talking about the same thing. So we could see our systolic pressure is higher than our diastolic pressure over here. And as we move into the area of our arterioles, the rate of flow is going to slow because we now have more narrow openings. So notice here's our velocity, so we can see the speed of that flow. And then we of course know that that is going to slow a lot once we get to the capillaries like we described before. So remember, our systolic pressure is going to be when the artery walls are stretching, whereas diastole is when those walls return to normal due to the elastic properties of our artery. Now, sometimes we can increase pressure because we have greater peripheral resistance. Essentially, that's resistance to blood flow. There's a couple of different ways to create this, but the one that really affects it is vasoconstriction and vasodilation. So when we vasoconstrict, we are increasing peripheral resistance, and that increases blood pressure. Okay, the last thing we're going to talk about is blood pressure regulation. So we have this term cardiac output, or CO, and this is our volume of blood that's pumped by the heart in 1 minute. So here is our heart. We pump that blood out through the aorta, and then, like we said, it's the volume of blood in that 1 minute. And then we have our heart rate. This is the number of heart contractions per minute. And lastly, our stroke volume. This is going to be the volume of blood that we have in our ventricle that is pumped into the aorta per contraction of our left ventricle. So again, another volume. And so if we are to have our numbers of heart rate and stroke volume, we can multiply them together to calculate our cardiac output. So if we were to, let's say, increase heart rate or increase stroke volume or increase both, we're going to see an increase in our cardiac output. Now you may be wondering, how can I change heart rate? How can we change stroke volume? Well, here's this great figure over here that shows us how. With our heart rate, when we stimulate our sympathetic nervous system, that's going to increase our heart rate. Certain hormones like epinephrine and norepinephrine can increase our heart rate. Our fitness levels and age will also affect our heart rate. Whereas stroke volume, our heart size is going to affect it. So if I have a larger heart, I'm able to carry a larger amount of blood in here, a greater volume. Our fitness levels and gender will also play a role. Contractility, meaning if I have greater strength in the contraction in my left ventricle, I can increase stroke volume. And then the duration of that contraction affects it, and our preload or end diastolic volume. What that refers to is if I have a greater amount of blood being brought back to the heart through the vena cava, I now have a greater amount of blood within the heart, which means once I get to the left ventricle, I should have a greater volume as well. And then we have afterload or resistance. That is talking about the resistance we have within our aorta here. So the greater resistance I have, the less or decreased amount of stroke volume will result. If I have minimized or decreased resistance, then I can increase my stroke volume.